All right, can everyone hear me okay? Yes, no? All right. I apologize in advance for my dog. She's decided that now would be a good time to act crazy. Okay, well, let's start. Okay, so I'm just going to start by saying if you didn't do anything over Thanksgiving break, don't freak out. So last year at this time, I flew home to visit my family, and I had every intention of studying and ended up not like opening anything. So I remember, kind of freaking out when I came back. Um, but, just try not to do that. Like I still did fine on this exam. So like, don't freak out. You still have time to learn this. Basically what I'm getting at. Um, and don't feel bad for taking a break because you deserved it. Okay, so I wanted to draw your attention to this right here on Mediasite. If you look under additional videos, there are lab dissection videos, and I think there are several videos that cover like the neck and the head and the stuff on this exam basically. So if you haven't looked at that before, that might be helpful if you're kind of pressed for time and can't get in the lab. All right. So I know you guys have a TBL tomorrow, so I'm going to try to get through this as quickly as I can. And I'm going to focus on pointing out what I feel like is going to be high yield for the exam. So hopefully that is the most helpful at this point. Okay. So let's start with the IT fossa lecture. So hopefully at this point, you know your standing room only mnemonic, and that V1 passes through the superior orbital fissure, V2 through the foramen rotundum, and then V3 through the foramen ovale. And remember, when we say V1, we're referring to the ophthalmic division of the trigeminal. V2 is maxillary, and then V3 is mandibular. So kind of be comfortable with interchanging those names because you could see it different ways. And then also remember that V3 is the only branch that's offering motor innervation. And Dr. Leo kept saying, V1 to the orbit, V2 to the pterygopalatine fossa, and V3 to the IT fossa. So kind of just big picture here to get us oriented. And then of course this picture here is showing where that sensory innervation hits the face for each of those three divisions. So keep that in mind too. Okay. So people keep asking me about Dr. Leo. I know you guys are kind of probably on the fence about him right now because I think these are the first lectures that he's taught and you haven't had exam questions from him. My advice is if you did not take very good notes in his lectures, I would go back and listen on double speed. Luckily, he speaks pretty slowly. He does that on purpose so people can take notes. And you really can't just study from his slides. To really get the big picture, and a lot of what he asks is also going to be on what he says. So if you want to re-listen to anybody, I would suggest him. But also know that he is very fair. Like if you know what's in his lecture, then you'll do fine on his questions. Okay, so as far as the IT fossa goes, both of the fossas really, they spend a lot of time talking about, boundaries of this, yada yada. That's more to just get you oriented and to help you understand like where exactly these fossas are located. where most of your test questions are going to come from are from the contents of those fossa. So, whether it be muscles, arteries, or nerves, that's what you really need to focus on. Like, don't sit here and memorize, oh, what's the roof? What's lateral? That's probably not the most high yield of your time. I would focus on the contents. So in the IT fossa, we have the medial and lateral pterygoid, the temporalis muscle, V3, the maxillary artery, and the sphenomandibular ligament. So kind of get these in your head and know what you're looking for in the fossa. All right. And then, all right, so you see that this is the slide with all the stars. So this is where most of your questions from this lecture are going to come from. Okay, so start up here with the auriculotemporal nerve. So I believe in Dr. Coleman's lecture, he showed you a picture of the ear and how it's actually receiving sensory innervation from 3 different nerves. So one of those nerves is the auriculotemporal nerve. So remember that is innervating part of the external ear, most specifically like the more anterior part. But we'll get there, I'll show you a picture. And then another very high yield thing to remember is that you will see the auriculotemporal nerve splitting around the middle meningeal artery. So I can promise you that the middle meningeal artery is going to be significant, probably for more than one question. They could either tag this artery and show the auriculotemporal nerve splitting around it, or they could like feed a pipe cleaner through the foramen that it passes through. So what foramen in the skull does the middle meningeal artery pass through? Right, the foramen spinosum. So that right there is very high yield. I think that's how they did it on our practical last year. Okay, and then also important to know is your parasympathetic innervation to the parotid gland. So it's the postganglionic fibers, so postganglionic parasympathetic fibers from cranial nerve 9, your glossopharyngeal nerve, that are leaving the otic ganglion, and they're traveling with the auriculotemporal nerve, so they're hitching a ride on it to reach the parotid gland and provide it with parasympathetic innervation. So very important to know this little drawing right here. All right. Next we have the inferior alveolar nerve. So the way they like to tag this, they'll probably either tag the inferior alveolar or the mylohyoid. If somebody has, hopefully you've seen the mylohyoid in lab. It's very tiny, but in a, sizable person, they might get one big enough where they could get a string around it. So this inferior alveolar nerve, it's going to enter the mandible and get these mandibular teeth down here. So if you have a dental procedure, this is the nerve that they're going after, and he mentioned that this is also why your chin tends to feel numb if they numb you down in your jaw, because you have this mental nerve that exits the mental foramen from the inferior alveolar. And then so this mylohyoid nerve, this is the one I tagged, and you're going to see it coming off of the inferior alveolar before it enters the mandible. So make sure that you've seen that in lab. So the auriculotemporal nerve is branching from um, the third division of the trigeminal nerve. So I believe the cell bodies that you're seeing here are post ganglionic parasympathetics from cranial nerve 9. Okay. Another important one to know is that the lingual nerve is supplying sensory innervation to the anterior 2/3 of the tongue. So make sure you understand the difference between sensory, as if somebody poked your tongue with a toothpick, versus taste, where it would be like um, somebody sticks a lifesaver on the tip of your tongue. So the sensory innervation is from the lingual nerve, which is a branch of V3, whereas the chorda tympani is coming from cranial nerve 7, and that's providing taste to the anterior 2/3. So very high yield to know taste and sensory innervation, not only to the anterior 2/3, but also the posterior 1/3. So what is doing the posterior 1/3 of the tongue? Right, the glossopharyngeal. Okay. Okay, then I talked about the mylohyoid nerve, innervating the mylohyoid in the anterior belly of the digastric. So yeah, the mylohyoid I think is one that gets tagged often. That and the inferior alveolar. Okay. And then this is just again explaining the innervation of the parotid gland. So you can look at this drawing if it helps a little more at all. Okay, and then I left this in here, but I don't think he talked about this. Yes, no. Oh, you did? Okay. Yeah, so I would just, be familiar with these two, but I definitely don't remember being tested on these, so not a huge deal. Okay, but what is a huge deal is being able to identify 4 muscles here. So the temporalis, the masseter, the medial, and the lateral pterygoid. And then, so first of all, don't worry about origins and insertions for these. I definitely don't remember that being a focus at all. But what you do want to think about is the function. So the lateral pterygoid is kind of the oddball here, and why would that be? Why is the lateral pterygoid different as far as its function? Right, it opens the jaw and it also protrudes the jaw, whereas the other 3 um, are lifting the jaw or helping to close your mouth, or retracting the jaw. All right, there's a slide on this. I think it's the next one. And then, yeah, we've gone over these nerves. So these are just pictures of them on the cadaver. And this little mylohyoid nerve right here. Make sure you look at that in lab. Okay. Yeah, like I said, don't worry about origins insertions. It's very low yield. I would focus on the functions. So knowing that the lateral pterygoid is going to depress or open the mandible and protrude the jaw. I think we had a test question about that last year on the lecture exam. and then these two retract and all three elevate. Okay. The maxillary artery. Do your best to memorize all the branches. But honestly, I would focus the most on the ones that they spend a lot of time on. Like, for example, obviously you need to know the external carotid, the middle meningeal, uh, anything passing through the PT fossa, um, I mean, accessory meningeal, who cares about that one? So this website right here, there's a mnemonic to help with that. It's not super appropriate, so I didn't write it out here, but I guess it wasn't too appropriate that Radiopedia couldn't have it on its website. So I thought that was kind of funny. But you can look at the mnemonic if you go to the site. Okay. Next is the TMJ. So the biggest thing I would focus on here is knowing what nerve is innervating this joint, because that's really the biggest problem with this is it's causing people discomfort. So you want to know that the TMJ is innervated by the auriculotemporal nerve, and then just have an understanding that this joint, I mean this right here, is just kind of like popping out. Yeah, so not too terribly important. Just know the innervation. Okay, and then I left this in here. This is a cool thing you could go through and practice labeling, if that helps. All right, let's go on to the PT fossa. Okay, so this picture right here, this gets really everything we're going to talk about tonight. Okay, so the PT fossa and everything that's exiting through the different foramen, and then all of V1, and then all of V3. So we're going to hit all of this, but if you need to like see it all in one place, this is pretty good here. Okay, so I know last year I don't know, when we did the PT fossa, I was like, I have no idea what's going on. But honestly, everything in that lecture can pretty much be, or everything that you need to know at least, can really be summed up in this chart right here. And I just want to make sure that you understand how to read this chart. Okay, so if, say, we're standing inside the PT fossa and, we're facing forward with the skull. So if you look laterally to get into the IT fossa, to get into that next room, you're going to have to pass through the pterygomaxillary fissure. And when you do that, the maxillary artery is also going to go through the door with you. And then if I look medially, I want to get in the nasal cavity, and to get into that room, I have to pass through the sphenopalatine foramen. And walking through the door with me is the nasopalatine and the posterior superior nasal branches and sphenopalatine artery. Okay, so you can go down through this chart, and this is what you need to know. Okay, so your exam questions are going to come from basically what nerve and arteries are traveling through the door and where are they trying to go. So if you just sit and memorize this, you are going to be fine. And it's really not as bad as it seems. Like, for example, 3 of your posterior foramen. Okay, so to get into the pharynx, going through the palato-vagal canal, we have the pharyngeal artery and the pharyngeal nerve. So that really makes a lot of sense. And then you already know standing room only. So V2 is passing through the foramen rotundum. And I think, like, once you've studied all the lectures, you're already going to know a lot of this stuff. Like the oral cavity, you will already know these at that point. So don't freak out about this lecture. Know this stuff here, and you should be just fine. Okay, and then I included this. As far as I know, I don't recall if they were to tag anything about the PT fossa, it would be like an artery or a nerve. But honestly, most of those branches are so tiny. I think they really hit the PT fossa on the lecture exam. So yeah, if it seems too small for them to tag or you haven't seen it in lab, then it's probably not going to be on there. Okay, so Ashley drew this last year, and this is how I learned it. So, the chicken bucket model, and this has all of those branches on it. Oh, I also wanted to say, so last time I didn't focus very much. So in lecture, they don't really focus a lot on the muscles of facial expression. But just keep in mind, those are all on your lab list. And they definitely tagged more than one last year. So I'm talking about like the orbicularis oculi, orbicularis oris, like all of those small facial muscles. Make sure you know those really well because those could definitely be tags. So I just want to give you a head up there because I don't really spend a lot of time on it in lecture. Okay, development of the head and neck. Okay, so this right here is a video, and somebody made this chart here to go along with this video. And this guy just kind of gives you some mnemonics to remember some of this stuff. So you can go watch this video if you think it'll help. But most of what he said is right here. Okay. Oops, sorry about that. Okay, so I know everyone always stresses about Dr. Gasso's lecture, so I try to give you some hints as far as specific slides. So basically, anytime he had a summary slide in these lectures, that's all you need to know. Like, for example, he had a slide that said, the take home pharyngeal arches, which was basically what's in this chart. That's the only slide that you need to know about this information. Okay, so let's go through this real quick. If you've seen this slide floating around before, I made a couple changes because it wasn't like 100% correct. Okay, so your first arch here is forming Meckel's cartilage, and you have a maxillary and a mandibular portion. As far as muscles go, only the mandibular portion is giving rise to muscles. So these muscles here, and then I tried to color coordinate it to make sense. And then the maxillary portion is giving rise to these here. And then the mandibular portion, of course, the mandible, the incus, and the malleus. Okay, so make some important stuff. So the second arch is forming Reichardt's cartilage, and it's associated with the facial nerve. And I kind of think maybe she has a smiley face here. I remember last year, the questions on this weren't that difficult. Like, I think one question was as simple as which cranial nerve is associated with which arch. Like, for example, like if he asked about the second arch, then it would be the facial nerve. Okay, let's see. I'm not going to read all this to you. The one I wanted to point out here, though, is the glossopharyngeal nerve innervating the stylopharyngeus. So this is one they like to ask about because the glossopharyngeal nerve is only offering motor innervation to one muscle, and that is the stylopharyngeus. So I really should have put a star by this one. So go ahead and put a star by that. That's one that's commonly asked about. Okay. So do your best to to try to remember all of this, but if you're kind of like panicking and triaging, make sure you get the stylopharyngeus, and then make sure you can associate which nerve goes with what arch. Okay, and then I would be very surprised if you asked about these because so far we haven't talked about these at all in second year. So I think this is fairly low yield. The one that is extremely high yield and that gets brought up over and over again is DeGeorge syndrome. And I think you might have also talked about this one in MFM. So that's a 22q11 deletion. So they call DeGeorge a catch-22. If I were to know any of the clinical correlates from this lecture, I would know this one. So they're going to talk about, absence or lack of development of a thymus or parathyroid glands. They'll talk about low calcium. As far as cardio goes, DeGeorge is very commonly associated with tetralogy of Fallot. So I would recommend knowing this one. And then, let's see. So as far as the other stuff on this slide goes, so make sure you kind of understand what's going on here. So you have pharyngeal pouches, which are formed by endoderm, and then pharyngeal grooves formed by ectoderm. And they're going to come together and fuse and form these pharyngeal membranes. And the only one you need to worry about is the first pharyngeal membrane, which gives rise to the tympanic membrane. I honestly can't remember what he asked about from this last year, but if he were to ask about one, I could definitely see this one here. Because he said that, they no longer think that the external acoustic meatus is formed from the first pharyngeal pouch or the first pharyngeal groove. It's now formed from the first arch. So there's really not anything here that you need to worry about, just because the second arch is overgrowing the second, third, and fourth clef, and you're getting the smooth neck. And then just be able to associate the pouches with each of these structures. So know this column, and then know the pharyngeal membrane and DeGeorge syndrome. And then I doubt they'll test you on this because this was actually on our most recent exam. But if you have a branchial fistula, you have a persistent second groove, and then a cervical cyst is a persistent cervical sinus. All right. So most important to know from this slide is the fact that your thyroglossal duct is going to disappear or regress, and then that remnant is the foramen cecum in the adult tongue, which I think you should talk about in the oral cavity lecture. And then you can also have a pyramidal lobe of the thyroid gland from this thyroglossal duct as a remnant of it. And then the most important clinical correlate here is this thyroglossal duct cyst. So if the duct does not close, then you get a cyst in the midline of the neck. So if they talk about some sort of cyst in the midline of the neck, it's the thyroglossal duct. If it's in the lateral portion of the neck, it's a branchial cyst. So just associate those locations. Okay. All right, so embryology of the tongue. So the anterior 2/3 is known as the oral tongue, and then the posterior 1/3 is known as the pharyngeal tongue. By far the most important thing to know here is the innervation. For sure, this is a question. Okay, so remember that the anterior 2/3 of the tongue. Taste is coming from the chorda tympani of cranial nerve 7. And then your general sensation, like somebody trying to poke your tongue with a toothpick, that's from V3, or more specifically, the lingual nerve. And then the posterior 1/3 is getting both sensory and taste from cranial nerve 9. I don't remember it being tested on the epiglottis, but just in case, here it is. And then motor innervation to your tongue muscles is going to be cranial nerve 12. So they like to get you on this just because it's hard to remember. So make sure you know that. And then also the slide with development of the tongue innervation, that's the one from his lecture that you need to know if you're trying to match this up with the lecture slides. All right, so he had a slide that was summary of facial development. Make sure you know that one. So I think the way that we were tested on this last year, it was in the context of the cleft lip and the cleft palate. So a lot of these, all of these swellings are contributing to the face. And, a lot of these make sense if you just think about it. So the maxillary swellings, for example, are the upper lip. The medial nasal swellings are giving you your nasal septum. All right, so look over this. But what you want to try to understand is the difference between a cleft lip and a cleft palate. So your cleft lip, first of all, it's more common in males, and this happens when the medial nasal prominence and the maxillary prominence fail to fuse. So if we look back here, the medial nasal prominence is the nasal septum, and then the maxillary prominence is the upper lip. So that kind of corresponds with what you're seeing here, because that defect is more anteriorly, and it's through the upper lip and reaching up into the nasal cavity. And then the cleft palate, you can have either an anterior malformation or a posterior malformation. The anterior malformation corresponds with the intermaxillary segment, which is part of the primary palate, and then the posterior malformation is going to correspond with the maxillary prominence. So basically what this is saying is that the anterior, the defect is going to be located more anteriorly in the palate, and then the posterior malformation, the defect extends further back. Okay, so make sure that you can correlate this to what you see in this chart. I'm 99% sure this is what he asked about last year. All right, on to the orbit. So this lecture, this lecture just keeps coming back up. This is all stuff that's really important to know from here on out. I don't know if on this upcoming EPC exam that you guys have the lecture from Dr. DeFranco on the eye, but a lot of this stuff is going to come back up in her lecture and on your EPC exam. Okay, let's try to get through all this. Okay, so first you want to know the bones that are contributing to the orbital, the orbit. So the zygomatic bone, the maxillary bone, the lacrimal bone, ethmoid, sphenoid, and frontal. So you could get a question about, what bones are making up the orbit. That's something that I've seen them ask before. Okay, and then Aaron, his name's Aaron, right? Yeah. So Aaron, in his lecture, talked about the orbital blowout fracture. So what direction are orbital contents most likely to herniate if somebody was to, come up and punch you in the face? Right. Yeah, inferior is most common. And then, yeah, he also mentioned into the ethmoid air cells. So Yeah, I would say inferior and medially, with probably inferior being more common because you have that large maxillary sinus down there. Okay, of course you need to know the foramen, but over here, definitely be familiar with your orbicularis oculi and the fact that it has both an orbital and palpebral part. And somebody correct me if I'm wrong, but I believe it's the palpebral part is for like soft, what they call soft closure, and then the orbital part is like if you like are trying to really close your eyes so somebody can't open them, like you're really closing them hard. Okay, and then we also have the levator palpebrae superioris, which is responsible for um, lifting the eyelid. Yeah, so right here. And then its insertion is this superior tarsal muscle known as the Mueller's muscle. Um, so if you have a weakness in either of these, mainly the levator, what symptom are you going to have, or what is that going to result in? What's the clinical term for that? Right, ptosis. Exactly. Drooping of the eyelid. Let's see what else here. Okay. Make sure you know your nerves that are innervating the eye, but we're going to get into that, so I'm going to keep going. Okay. So I added this one in from Aaron's lecture. So if you have a blockage of the tarsal glands, what is that called? Right, chalazion. And if you have a blockage of the ciliary glands, what is that called? A stye. And which one is painful? Right, the stye. Okay. And then the other thing to note here is that you have a palpebral part and a bulbar part of the conjunctiva, and where they're reflecting on one another is known as the superior conjunctival fornix. Okay. Okay, so I noticed that he went into these ligaments and tendons. To be honest, we didn't learn that last year. Um, I don't think it's that clinically significant unless you're like going to be an ophthalmologist. So I would focus on the eye muscles, and then I would focus on the nerves. I was trying to remember why I put a star by infraorbital. Okay, yeah, I just wanted to point out that remember your infraorbital nerve is coming from V2 instead of V1. That's really the big difference to note here. Okay. Next we have the lacrimal gland. So you want to try to be familiar with the flow of tears across the eye. So when you blink, the fluid is going to move from laterally to medially, kind of like a windshield wiper moving across the eye. So you go from the lacrimal gland to the ducts, to the puncta, to this canaliculus, and then the nasolacrimal duct out into the nasal cavity. Let's see. So you want to know that the deep petrosal nerve right here, which is carrying your sympathetics, and then the greater petrosal nerve, which is carrying preganglionic parasympathetics, they're going to meet up here, and they're going to travel through this pterygoid canal. And then at that point, the postganglionic parasympathetics It's almost like they're climbing a ladder to get up here to the lacrimal nerve. So you want to kind of be familiar with the path that these nerves are taking, through the zygomatical temporal up to the lacrimal nerve to innervate the lacrimal gland. Okay, and that's kind of written out for you here. All right. I remember I did this. Okay, so inferior oblique. This is the one they tagged last year in the practical. So what they'll do, like a lot of people don't really take the time to dissect this one out. But if you know where it should be, it's pretty easy to figure out like what they're tagging. So the inferior oblique runs kind of sideways, and they'll kind of pull the eyelid, the lower eyelid down, and they'll kind of pull this muscle out and they'll tag it. And you see it running kind of medial to lateral. So that's going to be your inferior oblique if they happen to tag that one again. Right. And then, of course, you need to know the rest of the muscles. If you're trying to determine if it's superior rectus or the levator, the levator should be reflected so that you can see the superior rectus. But other than that, they should be pretty straightforward as far as medial, lateral, and superior rectus. Okay. This slide is hugely important. So you need to make sure that you know the function of each of these muscles. So superior rectus is going to elevate and adduct. The inferior rectus is going to depress and adduct. Your lateral rectus is just slowly abducting, medial is adducting. And then I think the two that are a little bit difficult to remember is the superior oblique. So that's going to depress and abduct. So the way I've heard that people remember this is that 1 minute you could be superior, and then the next minute you're down and out. So 1 minute, you're up high, and the next minute you're down and out. So that maybe will help. I don't know, it's kind of dumb, but it might help you remember the function of the superior oblique. And then this here, okay, so in order to test the motions of the eye, so you have to use the H test, of course. And the reason that you're moving the eye up and out to test the superior oblique is that, the superior rectus, is that the eye has to first be out, and then the only direction it can move is either superior and inferior. Because if the eye is in a neutral position, the inferior oblique could also be helping the eye move up. So basically, by having the patient, follow the pencil laterally first, that basically locks things out to where the only muscle they can engage to look up is the superior rectus. And I apologize, it would be easier to show this to you in person. So if that doesn't make sense, I would try to get with somebody who understands this, because once you finally get it, it's not a big deal. But I know the first time learning it can be really confusing. But anyways, make sure you know the function of each muscle, and then how would you test that muscle. All right, and then I also wanted to point out, so I have a question over here. If you have a lesion to cranial nerve 6, what is the clinical condition that is a result of that? First of all, what is cranial nerve 6 innervating? What muscle? Right, the lateral rectus. So if your lateral rectus goes out, what muscle is taking over? right, the medial rectus. And then what do we call that clinically? Right, esotropia, right, or medial strabismus. That's more of an EPC question probably, but still a tough question nonetheless. And then this one's a little bit more difficult to understand. So what happens if you have a lesion to cranial nerve 3? Think about the muscles that are left over. Like which eye muscles would still be innervated? Right, the lateral rectus and the superior oblique. So if the other extraocular eye muscles have lost their innervation, then which direction would the lateral rectus and superior oblique cause the eye to move? Right, abduct and depress. So it's going to be down and out. So basically the function of the superior oblique is taking over. And then of course, the lateral rectus is helping it. So abduct and depress if you have a lesion to cranial nerve 3, because superior oblique and lateral rectus are now unopposed. So hopefully that makes sense. I know there's a ton of YouTube videos on this. So if you need to see it to make sense, I suggest going to YouTube. Okay, these are just donor images of the muscles that you can look at. Oh yeah, here's that inferior oblique. So this is how they tagged it last year. They kind of pulled it out, and then they had a tag there. Okay, I think we talked about these. I don't know. I don't think they went over. Well, maybe Aaron did a little bit. Papilledema. I wouldn't worry about that. I don't remember being tested on it. I would know lesion to cranial nerve 3 and then the medial strabismus. Definitely know those two for now. Okay. So this one here these pictures here are very important. So you really got to know all the nerves up here in the orbit. Let's see, where do I want to start? Frontal. Okay, so right here is your trochlear nerve. So innervating the superior oblique. And then you can see the frontal, which is part of your NFL, and then the lacrimal nerve. And then the frontal is going to split into a supratrochlear and a supraorbital nerve. And then over here, we have anterior and posterior ethmoidal off of the nasociliary, and then also your short and long ciliary nerves. So just take some time and draw these all out, and make sure you understand where they're coming from. Okay. Yeah, and here are some good pictures of them in the donor to study from. Okay. So you definitely want to know both of these reflexes. So the corneal blink reflex, so you can see them here touching this person's eye, with a Q-tip. So the corneal blink reflex has two arms. So the sensory component is from V1, and then the motor component is from cranial nerve 7, which is causing your orbicularis oculi to close the eye and protect it. And then the light reflex, this is probably more of an EPC thing. If you shine the light into one eye, it's received by cranial nerve 2, but it's cranial nerve 3 that's actually causing constriction of both of the pupils. Okay. Um, the ophthalmic artery. I don't really remember this being a tag, but he did mention that it is traveling with a certain nerve. What nerve would that be? What nerve does it travel with? Just think about where it's going, right? Cranial nerve 2, and it's passing through what to get there? So it's going to pass through the optic canal. Um, as far as like branches of the ophthalmic artery up in here, yeah, definitely don't worry about that. Okay. In this slide here, you want to be aware of basically the layers of the eye. So you have a fibrous, a vascular, and a neural layer. Your fibrous layer is made up of the sclera and the cornea, which receives its innervation from the short and long ciliary nerves. And then you will also have an iris here in the vascular layer, and that's going to control the diameter of the pupil. And so the biggest thing here is just to be aware that your dilator pupillae is receiving sympathetic innervation, and then the constrictor pupillae is parasympathetic innervation. Okay, and then also realize that the ciliary body is important in accommodation. So this is basically changing the shape of your lens to accommodate for either near or far vision. Okay, and then I added this from his lecture. So it's important to understand, obviously, the difference between distant vision and near vision, because this is something that obviously, a huge portion of your patients are going to struggle with. So in distant vision, your ciliary muscle is going to relax, and that's going to increase the tension on the zonular fibers. So then the lens is going to flatten. And then this is important in myopia, which is nearsightedness, meaning you can't see far away. So yeah, make sure you don't get confused. If somebody says they're nearsighted, they can see near, but not far away. And then presbyopia is referring to farsightedness, and this is usually associated with aging. In older age, typically, people will struggle with seeing close up, or a lot of times, they can't see far away or close up, so then they have the bifocals. All right. So I would say the biggest thing to get out of this slide is that it's if you're not absorbing the aqueous humor, this is going to lead to glaucoma. This was not in our lecture slides last year, so he added this. I don't think it's super high yield. I would just make sure that you can associate the aqueous humor with glaucoma. And then you'll talk more about that in neuro. All right. Just 1 second here. Okay. So here's just another, drawing showing you the path of the sympathetics and the parasympathetics. So much more I can say about that. All right, let's go into the ear. All right, so here's that picture where he talked about the fact that the ear is receiving sensory innervation from 3 different nerves. So I know that the shading here is kind of different than what you saw in lecture, but just get the general idea here. Just that auriculotemporal is kind of this more anterior portion, and most importantly, know that it's getting the external auditory meatus, and then the greater auricular down here, and then the lesser occipital in the back, or the more posterior part of the ear. Okay, so this here was an EPC question at some point about the fact that the external 1/3 of the ear is cartilage and the internal 2/3 is bone. And then again, auricular temporal, getting the external auditory meatus. And then also the fact that your ceruminous glands, which are producing cerumen, they're located in the lateral 1/3 of the ear. So they're in that cartilaginous part. I think that's all that's important here. Okay. So he kind of mentioned these. We were not tested on any of these ear clinical correlates. There's a lot going on in the ear, and he only gets 3 questions, so this stuff's probably not the highest yield. Just makes the lecture more interesting. Okay. What I would focus on is the fact that the tympanic membrane receives so much sensory innervation. So, you've heard about people, rupturing this membrane, and, you can imagine why it's so uncomfortable. Okay, so first of all, the tympanic membrane, it's formed by what embryologic structure? Which one of the pharyngeal membranes should you know that's forming? Right, the first one. So first pharyngeal membrane gives rise to the tympanic membrane, excuse me. Okay, and that's going to separate your external and middle ear. And then I would know that the external portion of the tympanic membrane is innervated by these 3 nerves, B3, 7, and 10. Or did I say external? Yeah. So external, 3 nerves here, and then internal is innervated by cranial nerve 9. So if you were to perforate or rupture the tympanic membrane, something that could be injured is the chorda tympani. So what deficits would you see here? And he kind of showed you a picture where, sorry I don't have it here, but he showed you a picture where the chorda tympani was right in the vicinity of this membrane, right? You would lose taste, and then what kind of parasympathetic function are you losing? Which glands? Right, your submandibular and sublingual glands. So he kind of made a point of talking about that in lecture, so I just wanted to bring it up again. All right, moving on. Okay, so the 2 important things to know here are the stapedius muscle and then the tensor tympani. So tensor tympani right here, and then stapedius right here. And you need to remember that they are receiving innervation by different cranial nerves. So the stapedius is cranial nerve 7. And if you think back to Dr. Leo's facial nerve drawing, remember that this muscle was in that drawing. So that should hopefully help you keep that straight. Like if you've done that facial nerve drawing and you have that memorized, then you should be able to associate stapedius with cranial nerve 7. And then tensor tympani is the the third division of cranial nerve 5. Okay, so if you damage the stapedius muscle or say it's deinnervated, what does this result in? What is the clinical condition known as? Right, but what's the term? Right, hyperacusis. So basically, all of those loud noises, they're not being dampened, and everything's going to sound just really bright and uncomfortable and just too loud. So that can be uncomfortable for the patient. Okay. Yeah, so very high yield to know the innervation of these two. What they did last year is they set out a model of the inner ear like this. And I want to say they tagged the tensor tympani, but definitely know both of those. And then also, of course, the inner ear bones, the malleus, the incus, and the stapes. Make sure you know which one is which, because that's another potential tag. Okay. I added this in straight out of Dr. Coleman's lecture because he spent some time on it. Okay. I wish I would have put more stars here because they are definitely going to tag either the tensor veli palatini or the levator veli palatini, and they're going to do it from this view. So basically, the donor is where you have like a sagittal section. Hopefully that's the right word for it. But like you're peering into, you can see like the side of the nasal cavity, like the lateral nasal wall. Hopefully that makes sense. If you look from that view, you can see the tensor veli palatini and the levator veli palatini. And they're gonna probably tag one of them and then ask for the innervation because this is hard to remember, in my opinion. Okay, so what is the innervation of the tensor? So tensor veli palatini. Anybody? Right, V3. And then levator is cranial nerve 10, right. So like put 1,000 stars by these two here. Be able to identify those and then know their innervation. Then he also talked about when you swallow, these muscles are elevating the soft palate to basically block your oral cavity from your nasal cavity so stuff doesn't come out of your nose. So fun fact there, but definitely the most important part is identifying these muscles and then their innervation. Okay. Oh yeah. Then he talked about how if you yawn or swallow, this cavity is normally collapsed, but it's going to open it up by engaging both the tensor and the levator. So if you're on a plane and your ears are like clogged or whatever, and you yawn, this is what gets them to pop. Okay. Then just a picture to look at of the donor showing these muscles and nerves. Honestly, I mean, like, don't bank on it or be mad at me if this doesn't happen, but I would think they would use a model for this inner ear stuff. So make sure, if you guys have an ear model, do you have an ear model? If you do, make sure that you look at that and you can identify everything on it. Okay. Okay, so the inner ear. Okay, so basically, it just comes down to knowing the parts here. So your bony labyrinth um, is made up of semicircular canals, a vestibule, and a cochlea. Um, Within the cochlea, so I would say he didn't really spend a whole lot of time talking about this. You talk about this a lot in neuro. I want to say that last year, this is where the question came from. So you want to know this right in here really well. So you have these hair cells or stereocilia attached to the basement membrane, and this is what's going to vibrate, and then the tectorial membrane stays stationary and causes these cells to bend, which sends an action potential creating the sound. But really, the biggest thing to know here is where that your low and high frequency sounds are coming from. So your low frequency sounds are best heard at the apex of the cochlea, and then the high frequency sounds are coming from the base. Um, so this leads to something that's known as presbycusis. And what is that? Someone explain what. Right, age-related hearing loss, and it affects the high frequency sounds. And this is because high frequency is best detected at the base. So the base, of course, it kind of makes sense that this would be the first to be affected with age. So would you call this a sensory neural hearing loss or a conductive hearing loss? Right. Yeah, it's a sensory neural hearing loss. Okay. Um, this slide here is just explaining, how the sound wave travels from the external ear to the inner ear. So sound waves are going to hit the tympanic membrane and then, set off the chain reaction in the ear ossicles. And then you eventually get the stapes, against the oval window, causing that movement of fluid. It reaches the cochlea and it's transmitted, it's either a high or low frequency sound. I wouldn't worry too much about the physiology involved in this, just because you're gonna get into the actual physiology in your physiology course. So right now, I would just focus on the anatomy part of it. So knowing where everything's located, muscles and innervations. That's the big thing to really get from this exam. You're not going to get physiology questions. Okay. We spent a little time talking about tinnitus, so that's ringing in the ears. I don't think you'll really be tested on this clinical stuff too much. He only gets 3 questions for this, so I think he'll probably stick more to the anatomy. He talked a little bit about benign paroxysmal positional vertebra, so that's due to dislodgement of the otoliths from the otolithic membrane, and they fall into the posterior semicircular duct. So you're going to spend a lot of time second year in neuro talking about dizziness and all of this kind of stuff. So yeah, I would definitely focus more on the anatomy at this point. Okay. So I wish he would have stressed this slide a little more, because we weren't taught this in class, and this is going to take a lot of stress off if you can just remember this. Okay, so anything that starts with tensor is innervated by V3. So the one we just talked about, tensor veli palatini, is innervated by V3, right? So if it has the word palate in it, it's innervated by cranial nerve 10. So when we talked about levator villi palatini, that tells you cranial nerve 10. And then also recognize that, they're numbered for a reason. So number 1, that rule always trumps number 2, and so on. And he explains that down here. So tensor villi palatini has both tensor and palate in it, but rule number 1 takes precedence. So that's telling you, the tensor villi palatini is innervated by V3. So if you can remember this, if you get super nervous in an exam like I do, just go back to these rules, and that should help trigger your memory for a lot of these. Okay. But this is great. Super helpful. All right. So that's all I have for tonight. Next week we'll go through the last lectures, and hopefully at that point it's just more of a review, or if you have specific questions. And I'll try to, I know for me, tutoring is most helpful when people kind of like clue me in to like what's important for the exam. So next week with those lectures, I'll definitely keep that the focus, like, what's high yield? Yeah, you're welcome.